It's 8:02. So let's get rolling here. So welcome back to another episode of the New Dentist Show. It's number 9 or 10, I think now, which has been quite a journey for all of us. And I'm proud and honored to bring on Dr. Mick Falkel now. And in someone I've met through the ACT COVID conference, what was it, probably 4 or 5 weeks ago or something along those lines. You were talking at the end about anesthetic, and I hopped on because I started using Onset, which we'll get to that at some point in this hour. But it's an honor to have you. Thanks for hopping on.
Kevin, thanks for having me. I got to say, when you jumped on that call, you kind of saved me, because I don't know if you remember, but my slides weren't working.
Sure.
And so Mark Hyman and I just decided to have a conversation a little bit like this, and then you popped on the screen and you saved the day. So the least I could do is come on and help you.
It was a warm up act. This is what it comes to, right? So. Let's just get going, because I actually missed the beginning part of your lecture. So I would love to hear more about you. So let's start with that and what got you into dentistry, and kind of let's start with the path going forward from there.
All right. So it depends on how far you want to go back. But, essentially, I came from a pretty, my dad died when I was very young. And so I didn't have a dad. And I started skiing when I was young and became a racer. And then, I would race all over the world. Actually, I got very lucky to get on the Vermont national team, and I was moving in the direction of racing full time. And during the middle of the winter, weekends are busy in ski areas, but the weekdays aren't so busy. And so we would, occasionally get on the chairlift with somebody, and it seemed like every single time I got on the chairlift during the middle of the week, it was a dentist.
Sure.
And I thought, and I'd say, how do you have so much time off? Well, I make my own schedule, and so it was never a physician. It was never a lawyer. It wasn't the other things that I considered. So I thought, these guys have it figured out. And then in the spring and the fall, when there was no snow, I'd cut school and I'd go play golf in the middle of the week, and I'd get paired up with dentists. I thought, well, these guys got it figured out. Sure. So I thought, it's a lifestyle. And so, it's also kind of where art meets science. And I have an older brother. He's 11 years older. He was getting a PhD at Pitt in exercise physiology. And I went to visit him, and it was as boring as could possibly be. His best friend was a dental student. And so I went and hung out with him. And it was kind of like arts and crafts and stuff. I mean, he was enjoying himself. He loved school, loved what he was doing. And I thought, that is it. I'm just going to stick with that. And so I was lucky enough, I guess you would say. I had a big injury before I got a full ride scholarship to college, got a big injury, broke my back and my hip. And that took me out of competitive skiing, and I lost my scholarship. So I just decided to go on to college. And so I finished high school at 16, college at 19, dental school at 23. So I was pretty young. I did a GPR, but I was pretty young when I finished. So, I'm a very old dentist now, but I don't feel like I'm that old of a guy.
Sure.
Yeah. So,
I mean, you must be just a brainiac to go through all this the schooling of that quickly. But I mean, this is
no. I was not. I was just. I'm always in a rush.
Okay, there we go. So just finding a way to be efficient.
Not that smart. It's that I'm that focused and willing to work hard to get where I want to go faster.
That's going to be a theme, I think, for the rest of the evening too, as we keep going. So, so then you went to Pacific for dental school. How was that experience there? So,
I really got lucky going to Pacific, actually. So I was enrolled to go to Harvard, and I'm from the East Coast. And so I'm from Vermont. And so I was enrolled to go to Harvard, and I came out for a summer vacation after my junior year in college, and in Santa Barbara. And I pretty quickly found out that this California thing is a very cool thing. And so I decided I might want to practice out here. So I started talking to all the local dentists, and every single one of them said the same thing. If you don't go to school in California, you will not get your board in California. And so at that time, it was true. When I finished school, it was true. It's not true anymore because they have the regional boards now. But when there was a California board, we have 5 dental schools. I think there's more now. I think there's 6. But we had 5 dental schools at that time. And that was plenty of schools to keep California full of their dentists. So they were pretty particular on who that they let through. So I ended up switching gears, going to Pacific. And it was the best thing that could ever happen to me. This was back in the the good old days of Art Degoni, and I'm not sure if you know who he is, but the school's named after him now. And he was the guy who started the dental education where you were a doctor from the first day you started school, and the teachers worked for you. And that was his philosophy, and it made us just so much happier all the way through school. And I think it was a more collaborative type of education. I know a lot of programs have gone to that in the last 35 years, but it was novel when I went to school.
Sure.
So I was very lucky to have that opportunity to go to that program. It's also a program that meets my MO. It's a 4-year program in 3 years. So, it was perfect for me.
Awesome. And then you went on the VA after that?
Yeah.
Was
So
that
I did
something
that.
that always intended to do that?
So, I was looking at all the different specialties, and I thought, I couldn't really decide which one I wanted to go into. And so I figured, here I am, I'm young, I can do a year in a general practice residency, and maybe I can figure out which specialty I would like to go into. So I chose the VA West LA, which is the biggest VA down there, and it's a monster of a place, and a lot of residents and a lot of different specialty programs. So it was a great experience. It's also associated with UCLA, so we did everything with UCLA's residents. So really, there was a really big pool of all of the different specialties for me to look at. And what I learned while I was there was that if you're a specialist, all your friends have to be dentists, and I like other human beings. So I thought, well, I'll just stay a generalist and try to be as good at everything as I can possibly be. The VA was an amazing experience for me because it was about 6 months of general dentistry, and you could do anything you wanted within the specialties, and then 6 months of almost any other thing you wanted to do in a hospital-based program. So I focused on head and neck surgery and radiation oncology. And the reason for that was I thought it was cool. And I also wanted to get as much experience as I could in stuff that I would never see in my practice.
Sure.
And so it makes dentistry seem really simple. And that was great. And so now, and ever since, for the last 30 something years, I'm on kind of our head and neck cancer team here in our area. And I'm glad I did that because, dentists really just aren't trained on how to take care of the head and neck patient if they're going to have radiation treatment. And there's fairly significant dentistry that has to occur in order to allow the radiation to be effective, and not only effective, but not have osteoradionecrosis afterwards. And so, unfortunately, now we're seeing, for all your listeners, if you really should be doing a thorough head and neck exam. Because this, HPV related cancer, I had 2 this week, last week, and working, I have to worked them up last week and I'm working on them this week. Both of them are younger than me. So I'm 56, one was 53, one was 48, and they're both HPV. And one guy's stage 4. Jeez. And that's any of us, right? It used to be smokers, drinkers, and chewers. It's not just smokers, drinkers, and chewers anymore. It's anybody, because HPV affects us all. So,
is there something in your examination that you do differently that you would recommend?
Yeah, I'm just thorough. It's a visual exam. It's you palpate everything that you can possibly palpate. If you don't know how to, assess somebody's head and neck, go grab a head and neck physician, a ears, nose, and throat guy, and they will be happy, I am sure, to teach you how to do a head and neck exam better than you learned in dental school. And that should be who you're referring to. Most people refer anything they see to an oral surgeon, and I love oral surgeons, don't get me wrong. But when it comes right down to it, this is a medical problem. And if they go see the head and neck surgeon, their medical insurance pays for everything. And so I've got a great relationship with our head and neck guys, radiation oncologists, the oncologists as well. But if you want to learn how to do a really good exam, get your ENT to help you with that. They'll be thrilled that somebody's taking the time to look, and they're the right place to send them anyway. There's things like Veloscope and all of that, and I think those are great, but quite often they throw up some false positives and things like that. So.
Okay.
You just get good at the visual exam and the tactile exam, and I think you can do a really good job.
How about ozone therapy for those type of patients?
So, I'm not an ozone guy, and so I'm did not just don't know enough about it to speak.
Okay.
But I don't
What,
treat those patients with ozone at all.
sure.
Uh, you
So
know,
if you see somebody, what are they manifesting in their mouth that you would see something that would be HPV related for the,
so HPV is just squamous cell carcinoma, right? So it's
sure.
just it's just a etiology of squamous cell carcinoma. And so, you're just seeing normal squamous cell, not normal because squamous cell carcinoma is not normal, but you're seeing the same presentation. It's just typed to HPV.
Gotcha.
So when they do the biopsy, they type the cells, and if it types to HPV, the good news is that it's that particular squamous cell carcinoma is fairly susceptible to radiation, which
Gotcha.
is great. But still, you got to find it. And the earlier you find it with any cancer, the better.
It's so important. I think, especially now with as busy as we are in practice, it's
Yeah.
just another reminder of saying you still have to slow things
Yeah.
down, see
Yes.
everything, make sure you're doing a thorough examination and do what they need to do in order to make
Exactly.
sure
And
we're
have your
covering it.
hygienist. You may even have the ENT come in and teach you and your hygienists, um, the exam, taking a lunch or whatever. And I'm sure that they'd be happy to do that. And then your hygienist can do it every single time they come in. And if they see anything, they can pass that off to you when you're doing your exam during the hygiene appointment. So,
And it's a wonderful referral source, right? I mean, how many times do ENTs say they see patients for ear infections? And they're like, no, it's
yeah.
something going on with your TMJ, whatever it may be, a muscle or joint or whatever, go see your
So,
dentist.
so by the way, as they're teaching you, you can teach them what you do, and
Exactly right.
they'll
So
probably become your patient, and then they'll be one of your best referral sources.
it's a great thing. So it's all kind of in collaboration. So then after you decided you want to be a generalist, what was your vision going forward from there?
So once I finished my residency, I had a dental school professor say, pick the place you want to retire and go make it work,
Okay.
which was great advice.
Sure.
Essentially at that point in my life, I could have gone anywhere, but I grew up visiting my grandparents here on the Monterey Peninsula. And my grandfather was failing. My mother had moved out here. And so I had been visiting during dental school. And every time I came, I got relaxed. It's a beautiful place. There's all this golf. I thought, well, what the hell? It seems like a nice place to retire. Why don't I give it a try? And I went to the local dental society, and they introduced me to a dentist that had been in a car accident who had also gone to Pacific. And he needed somebody to take his practice over while he recuperated. So I came and took over his practice. That was in an adjoining town, Salinas. And once he had a great guy, we had very similar philosophies. He taught me a tremendous amount. And I was able to step into a very busy practice that had neglect, kind of like right now, where we have all this pent up demand. So there was like an unlimited amount of work. So, big step up from school to residency in your speed. And then this was like a quantum leap step up for me because there was just all this ammunition for me to be able to treat. And so it was a great opportunity. At the end of the year, he had fully recuperated. And I found this job in this multi-specialty group that I joined. And although the group atmosphere, the multi-specialty aspect has changed in the last few years, I've been here ever since.
Gotcha.
So.
I mean, is this something that you came out with any idea? I mean, a lot of people we've heard that have been guests, they've all kind of clueless as opposed to, this is what I want to do. This is how I want to do it. Is this something that you had a distinct idea about how you want to practice, what you want to do?
Yeah. So I was a first generation dentist in my family. I had a nephew follow me. Unfortunately, he met a girl and he stayed in Portland. Otherwise, he'd be with
Sure.
me. But no, I mean, when I came out of my residency, I just knew I wanted to work hard and I wanted to be my own guy. Right? I was willing to work for somebody but at some point I had to own my own thing. And that was my goal. My goal was to get back to those guys that were skiing in the middle of the week and those guys that were playing golf and gals that were playing golf in the middle of the week. That's what I wanted. And so, I focused really hard on that and, I was able to make it happen. And I think, there's other options now that there weren't then. I don't know whether they're better options or not, but there's all this corporate dentistry, and there's, the DSO way to go. And I'm sure that's a great place to learn, and it may be a great place to have a career. I just don't know that much about it.
Sure.
But I know that there's still plenty of opportunity in what I did, and it sounds like your practice too, where we're private practice guys, and that is still a wonderful way to do dentistry. I wouldn't trade it for anything.
No, I totally agree with that. But
Yeah.
I mean, there's the beauty in dentistry is there's so many different opportunities for everybody.
Yeah.
Everyone's going to find their own path, hopefully sooner than later. But how did you get from working super hard to 2.5 days a week and doing the things that you like to do?
That seems like a big jump, doesn't it? Yeah. So essentially, what happened was, unfortunately I lost a son, and when something horrible like that happens to you, you just don't want to do anything, right? You don't. Sure. You don't want to practice. You don't want to be home. It's just hard. And so I needed something else to think about to get my mind off of it. And so, local anesthetic was pissing me off. I wanted to have a better opportunity to be able to treat my patients better. I was taught that if you could give in a painless injection, you could build your whole practice around that. Mm-hmm. Well, I worked really hard on that, and I was known as the guy in town, but I still had patients that thought it hurt, and that really bothered me. But it seemed like it was a chemical problem and not necessarily a technique problem.
Okay.
And then I hated failure, right? I hated to fail with local anesthetic because I always felt like it was my fault. And if I could fix that, that would be great. And then the most important thing, which is the theme in my life, is I love efficiency, right? I want to get through things as quickly as possible, but I don't want to skimp at all. I want to be able to do my job as well as possible, but get in and get out. And that's
perfect skier.
Yeah. So that's how I wanted to practice. And I was hung up on local anesthesia because it wasn't allowing me to do those things. So I was a chemist before I was a dentist. And so I just decided, you know what, I'm going to work on this thing. And then that became Onset, and our company, which is called On Pharma. And it allows you to, right now it makes a huge difference. We call it seat, treat, and complete. The CDC has given us these recommendations on how to keep ourselves safe, how to keep our staff safe, and how to keep our patients safe. And that's seeing one patient at a time. Well, if you're going to see one patient at a time, you better be really efficient. And if you're going to leave the room after you give anesthetic, you are now the vector of infection. Okay, so you better get in there, finish, and then take all your stuff off, move to the next room, put all your stuff back on after you've washed your hands and so forth. And if you're going to give anesthetic and have to sit there with the patient for 10 or 15 minutes while they marinate, that gets a little cumbersome. Mm-hmm. So if you can give anesthetic and go to work in a minute or two, or give anesthetic and find out you missed in a minute or two, so you can give another injection, and now you never really had to leave the patient and you haven't lost your stride. Well, now you can stay with the patient, stick to those CDC guidelines, and be able to work and be able to produce enough that you're making a good income.
Sure.
You and I were talking before we started. We've been back since June 1st. And June was my biggest month ever in my practice until July. And then it was 25% bigger than that. And right. So, I'm kind of hoping August isn't. I'm kind of looking forward to getting through this pent up demand. But I've always been very efficient. And so I took a 4-day practice, to answer your question, and brought it down to 2.5 days a week by the efficiency of no wait time. But also, if you're uninterrupted and you see one patient at a time, then you're 30% more efficient. Mm. If you're running in and out of the room and changing your gloves and changing your thought process, you just slow down. You may feel more rushed, but you're slowing the procedure down. You started using Onset. If you stay with somebody, all of a sudden the procedure's over way faster than you expected. Right. And so if you parlay that together, you can take a 4-day week and bring it down to a 2.5-day week and have the same production. I put my production when I was working 2.5 days a week up against any practice in the United States.
No, and also another thing is if you're just sitting there and you know that the anesthetic is going to kick in within a minute or so, it also gives you time to talk to the patient and actually have a genuine relationship with them, and know that I'm not bouncing in and out of the rooms. I think they appreciate that for many, one, sterilization, but also just a relationship builder.
Yeah. Well, I'll tell you what, what's really interesting is people will walk out of your office. Let's say you just sit down with the patient, you anesthetize them, you have your little conversation, you treat them, and then you dismiss them. Now you've just spent 30 or 40% less time with them. And they walk out and tell your receptionist, now that dentist spent more time with me than any other.
Yeah, right.
And you just spent 30 or 40% less time. So it's like a win-win, right? I mean, it's a better relationship, and yet you've been able to complete the procedure faster, which makes you more efficient and allows you to be more productive.
Awesome. I have so many questions, but let's start from the beginning, frustrations of anesthetic.
Sure.
So when you were trying your best, because Darren Becker talked about that too. Darren Becker was on our second or third week. And he said, yeah, to build a practice, you need to give good injections. And if you don't, you're going to have people walk. So what were you doing, or what are some things that you learned technique wise to initially facilitate some of those comfortable injections?
So, so when it comes to injection pain, you have the standards, right? You have the gate theory, right? So that is movement and pressure will override sharp and pinching. Okay, so and there's devices for that. You have the Vibroject. That's a little thing that sticks on your syringe. The one problem with that is the syringe is already intimidating and it's already big, and now you're
machine gun.
Hold on one second.
Sure.
Yeah. Sorry. Okay. So that's one. You have the one that's I forget the name of it, but it's like a little
fingers that vibrate, right?
Yeah, and it's got a light between it, which is nice. The lights in the oral cavity are always nice. That works. But you can also just shake your fingers and vibrate your hand as well. And so that was one that I still use, even though I'm using Onset. I can't give an injection without shaking my left hand.
Yeah,
it just doesn't happen. And, so that's a big one. Going slow is probably one of the most important things that you can do with an injection. And it's important for a couple of reasons. One, it's much more comfortable. But two, it's much more comfortable when it wakes up. And the reason for that is as you increase pressure to give the anesthetic quickly, that's like a liquid knife. So it's actually dissecting some tissue, which causes postoperative morbidity. So you have postoperative morbidity, which is the needle going through the wound, and that you're never going to get rid of. Because there's a needle going in. And so afterwards, that's going to hurt. You think about if you ever had just blood taken out, it hurts there for a little while afterwards. Well, that's the needle going in. But the tissue deeper than that hurts mostly from the speed that's going in and the acidity of the anesthetic. So if we can correct the acidity, that helps. But if you go slow, you're not going to dissect tissue. So the post-operative morbidity is going to be much better. It was popular for a while to heat local anesthetic. The idea behind it is, our body is 98.6. If you put the anesthetic in at a similar temperature, the body can't tell the temperature differential and it's more comfortable. Okay, great. I wouldn't heat your anesthetic much before the procedure. There's all these different instruments to do it with. I would just do it with some warm water out of the tap. And you want to just put it in a couple of minutes before, because you don't want it too hot. And you don't want to break down the epinephrine by light and some of these other ways that these heating elements that they're using. But that's another way to mitigate injection pain. And then really the one that works for all of those is buffering, right? Because we're going to put the anesthetic in at the right pH. If you mix the bicarbonate with the local anesthetic and use it right away, you have carbon dioxide in solution. That carbon dioxide is the most rapid form of transient anesthesia known to man. And it will go in, and it's not shutting off sodium channels. It's just distorting the nerve membrane. As you distort the little tiny C fibers, those non-myelinated fibers, that essentially turns off all the nociceptors. So now all of those different things, vibration, heat, all of these things that we were talking about are taken care of by the one thing, which is carbon dioxide, essentially.
Sure. No,
and so that's why buffering anesthetic it kind of hits all of those bases and you don't have to do those things if you don't want to. Now, I wouldn't recommend going faster. I had a lot of people in the beginning say, "Ooh, now I can give anesthetic like an oral surgeon," like that. But I still wouldn't do that, because, you want them to feel better when it's wearing off too. And that gives you time to tell jokes while you're giving them the anesthetic. So they appreciate it.
How long has buffering been around? Is this something that...
So buffering's been around in medicine since local anesthesia has been around in medicine. That's around the beginning of the early 1900s. And so it's been 100 years or more of buffering. Dentistry's never buffered it because we have the cartridges. And so, what I did was I figured out how to stabilize bicarbonate. Bicarbonate is a super simple compound. It's baking soda and water. And if you put baking and soda and water together, looks like champagne glass. It's all this effervescence. And that's carbon dioxide coming out of solution. And as the carbon dioxide's coming out of solution, the solution is becoming more and more basic. In other words, the pH is going up, and it can go up to 10 plus. And a base is actually much more caustic on tissue than an acid. So you need to be able to control that buffer, if you will, which is the sodium bicarbonate. So through physical chemistry, we were able to control. I can dial in any pH I want. So I had to figure out the right pH for the bicarbonate, dial that into my manufacturing process, and then have a vessel that will hold it there indefinitely. So because the pH of the buffer is very, very important. And so you'll notice when you buy the bicarbonate, it comes in 4 packs and there's springs. Mm-hmm. That spring is the physical chemistry. So it can raise in temperature, lower in temperature, and it's always at a dynamic pressure, which holds it at exactly that pH.
That's cool. I mean, did you work
that's
through
all, that? That's all my IP. So
that's your idea.
Team and so yeah. So I had a partner that I did this with named Matt Stepovich, who is he's a lawyer, I'm a scientist, and it's a weird combo, but it was a great combination for coming up with intellectual property and following trends, both scientifically and like a lawyer does, which a lawyer just doesn't believe anybody, right? So we had a good team working there that kind of figured all of those things out.
Was there a lot of trial and error during this process?
Just like anything, there's a lot of trial and error, but our trial and error was in the lab, not in the patients.
Okay.
You can use homebrew, which I call homebrew, or do it yourself. You can go buy medical grade sodium bicarbonate. And if you're going to give it to your patients, or you're going to do that, that is trial and error. And you're going to error more than you are successful.
What happens if that is an error? Because people mixing it.
Yeah. Well, so there's first of all, if you don't buffer the solution high enough in pH, then you get almost no benefit, right? So now your anesthetic's just as variable as it always was. Sure. Now, once in a while, the patient will say, "Oh, I didn't feel a thing," and the anesthetic will go right to work. But other times it won't, and it's just too variable. And so the other thing that can happen is that if you over buffer, you can have precipitate, and then you can have tissue damage and tissue necrosis, and you can have probably end up with some paresthesia, that sort of thing. You just need to be very careful. That's why onset is, it's always the right pH, so it always gives you the perfect solution to go in. Sorry. So anyway, I'm sorry about the phone and the other interruption.
All good.
I'm still at the office. It's the end of the day here in California.
I get it. No, the end of the day is a crunch time. So
that's that. You can homebrew. So there's 3 ways to buffer. You can homebrew, and it's going to be almost as variable as your own anesthetic, but you will have some success. It's very kludgy under these circumstances where we're worried about infection control. You got a lot of extra stuff that you got to do. Mm-hmm. And your infection control is probably not that good when it comes to those things, because we're not used to using vials and things like that. So that's number one. You could use there's a company called a Nutra, right, which is a different way of buffering, and they use a different syringe, which can pull up a greater volume. But they're using medical grade sodium bicarbonate off the shelf, and so you're going to still have the same variability because the sodium bicarbonate's not controlled. And then you have onset, which answers the variability problem, but it also allows you to buffer your cartridges of anesthetic. And our stainless steel syringes although they're kludgy looking and they're medieval looking, and dentists and patients don't like the way they look, they have a tremendous amount of feedback.
Mm-hmm.
And if you've ever tried to give an oral injection with a plastic syringe, so when I have to go to the emergency room, I always bring my syringes, because they just give me a plastic syringe and you miss your block like every time because it's flimsy and it's not working and so forth. So our dental syringe is that you've been trained on has a tremendous amount of feedback, and you really don't want to give that up. If you've ever tried using a different type of syringe, it's much more difficult. So, and you get to use all of our different anesthetics, right? You've got, you've got 5 flavors with 9 different strengths of anesthetic and so forth. So
Awesome.
you use your favorites.
I mean, I'll give you a little bit. I started using Onset since Mark Hyman was promoting it first week of COVID. So as soon as he started talking about it, I had no idea what this was. I had no idea how it worked, but he said this is something that it's a buffering agent. And I said, sure. And he's recommending it, painless injections or nearly painless, whatever it may be. And I got it, and it was almost too good to be true, and I didn't quite know because I was testing out patients and I was like, did you feel that? Like, how's it going? I'm numb quick. Yeah, I feel pretty numb, but there's no like comparative. So then finally I had a woman and she wanted me to do this on her. I did one side on the upper filling. I think it was 3, and then one on 14. I did one with Onset, one without. And she said there was a substantial difference in the comfort and the profoundness of the anesthetic almost instantly with Onset versus one that wasn't. So for me, it was like that one patient, I was sold.
Right.
I continued to keep using it. Patients find it to be very comfortable. I constantly said that I didn't even feel anything. It was something that was quite a cool process. So I've enjoyed it. I think it's been a great thing.
Have you figured out how to reduce the amount of time you're working with patients as you become more efficient?
It still kind of messes with me, to be honest with you, because I think I've been trained for the last 7 years to
hard to break old habits,
inject and then go see hygiene, because I still have to see my 2-3 hygiene patients at that point in time. So I'm getting used to it. I think having the endo ice was a good suggestion too. So that was something you mentioned during our talk, was get the endo ice, try it on the tooth that you're working on. If they're not feeling it, get started, and I've done that, which is helpful. Very, very helpful.
Well, what I would tell you about hygiene checks is, first of all, they're hygiene exams. They're not hygiene checks.
Right.
And the reason I bring that up is because we all call them hygiene checks, but that's not what they are. They're exams, and that's what the patient's paying for, is for the doctor to come in and examine them. I'm personally never checking my hygienist's work, because if I needed to, I would not employ them.
It wouldn't be working for you.
Exactly. Yeah. So it is an exam, and because it's an exam, that means you can go in from the moment they get in the chair until the moment they exit the chair. You can go in anytime you want. So because you're so efficient, so this is something to try. Just anytime you have something to do, go check the hygienist, right? When you're standing in the hallway, check the hygienist, right? Before you're going to go in for a crown prep or a extraction or whatever, go check the hygienist first, then go into the room. Because that way you don't need to leave and you're uninterrupted, and that's where the efficiency comes in. So, because it's one thing to save 5 or 10 minutes in wait time, it's another thing to save 30 or 40 minutes in efficiency, because you're not being interrupted. And that
was huge. So I started working with ACT 3 years ago, and that was one of the first things they recommended, was go in once all the diagnostics were done. So the x-rays and the probing or whatever may be done, and then you can do your exams, which was helpful, especially right around this time when things are crazy. You really can modify your time quite a bit. But I really am making an effort to make it so that if I'm in the restorative room, I'm staying in there, and it's been a change for me, and I'm working through it, but I think it's been far more efficient. And like we said, 30% more time is saved from just staying put and not jumping out of the room, which is important.
Yeah.
So I think it's a great thing. I've enjoyed it. I really have. I think it's something that, do you have one that you could just kind of show what it looks like? Is that something that?
Sure. If you want to, I can go grab mine.
I thought about asking you that beforehand, but
if you give me 1 second, entertain your guests, I'll be right back. Yeah.
So it's this green carpule that's probably about this long, and it basically takes out anesthetic and then puts in however 0.9 milliliters worth of solution of the buffering agent. And from there, it then infiltrates. And I think you have about 30 seconds to a minute to inject the patient in terms of having the most efficiency to it. but neutralizing it makes it far more comfortable. And I think my patients have really benefited from it. And then they also found that the timeline it takes to get numb is substantially faster too. So it's something I started describing it with, but you'll do a better job than I can. But
no problem. So let's see. So here it is. This is the one that I actually use in my office. And so there's this is what we call the onset pen. It holds a cartridge of bicarbonate. That's in a 3 ml vial. It's not filled to 3 mLs, but it's in a 3 ml vial. So you cannot confuse it with a cartridge of anesthetic. It's about twice the size. That drops into this pen, and then this gadget here is called the cartridge connector. And what that is, it's a conduit from the cartridge of bicarbonate to the cartridge of anesthetic. So when this is put to place, your cartridge, and you're ready to give anesthetic. I mean, I've already got my hands in their mouth, all right? Now, the assistant's just gonna place the cartridge in, turn this and push it together, and then you dial the dial. It goes to, it's a dial that goes up to 60, but you wanna dial 9. That's 0.09 mLs. Then you just push the button, reverse the steps, and now this cartridge, I like to say now it's a supercharged, right? So basically what this is it's a cartridge of anesthetic that's no longer at a pH of 3 to 3.5, but it's a pH of 7.4. Also, if you use it within the first minute, you have the dissolved carbon dioxide, which is going to give you the most painless injection, but it's also a catalyst to make local anesthetic work better. And as a chemist, I love catalysts. But you need to use it within the first minute because carbon dioxide is a gas and it will come out of solution and then it won't go into the patient. It's not going to hurt the patient, but it won't go in there and it's not helping either. And so that's why you want to buffer and then give the cartridge of start the cartridge of anesthetic within a minute, which doesn't seem like a long time, but I mean, it's 5 seconds when my assistants do it. You know, they buffer a cartridge, it takes 3 or 4 seconds, and then they put it in the syringe, hand it to me. If I'm going to give multiple cartridges, I'm doing a lot of real estate, then they're going to wait until I'm finished, buffer the next cartridge, put it in the syringe and hand it to me. They're not going to buffer them all. If I'm anticipating 3 cartridges, they're not going to buffer all 3 and then start using them. You buffer them one at a time. But it's very easy. I mean,
it's so easy. It is. I mean,
yeah,
just walking proof of that. It's
yeah.
Really.
So I mean, and you can use articaine. People love articaine.
Mm-hmm.
You know, my what I teach when I teach local anesthesia is you shouldn't have, you know, we have 5 anesthetics with 9 different formulations. You know, you don't need them all. You just need a couple, right? And you should be an expert at those couples. So, you know, I use articaine 1 to 200,000. I use plain mepivacaine, and I use 2% lidocaine 1 to 100 epi, and that's it. That's all I have. I don't need anything else. I can do everything with those 3 anesthetics. They're just way better when they're buffered.
No, I totally agree. No, Becky asked, does onset have any effect on how long the anesthetic lasts?
Yeah, so duration is not affected by buffering at all. Duration is affected by protein binding, and that's kind of patient to patient. You'll notice some patients chew up anesthetic faster. Some seem like they're numb forever. And that's just protein binding. The protein, by the way, is the sodium channel. And so the anesthetic binds to that, and then it's going to release at some point. And buffering doesn't change that at all.
What has an effect on that?
It's just the patient and the anesthetic. It's just how they react to that particular drug.
Gotcha.
And, so, and you know, it's a window, right? So if you're going to do an infiltration with, let's say, a local anesthetic with epinephrine, you would expect to have 40 minutes to 70 minutes. With a block, 50 minutes to 90 minutes, right? That's kind of all of our anesthetics with the exception of Marcaine. But Marcaine isn't a very good pulpal anesthetic, right? So that's the longer acting anesthetic, but it's really only good for soft tissue. And so we generally use that for pain control after painful procedures. But it's interesting because, you know, for years I've been trying to teach people to stay with the patient, and, you know, like yourself, right? It's hard habits to break, right? And so I was trying to fix a problem nobody knew they had, right? But now they have that problem because we've got COVID, right? So
Exactly.
so now it's different. But I could tell automatically in the early days if somebody stayed with the patient or they didn't, because the question they would ask would be the question, you know, the statement they would make would be, it seems like its duration is much longer. And then other people would say, it seems like it's shorter. Well, the reason for that is if you stay with the patient, you get every minute of the protein binding. If you go do something for 15 minutes and come back, you've lost 15 minutes. So you could, because now if you went and you didn't buffer and they didn't get numb until 14 minutes, well, now you have a lot longer. You find out that you have to wait for it to be bound. And so it doesn't change duration, but when you're more efficient, you don't need the duration to be as long. But what I always like to tell people, if you do want longer duration, whether you're buffering or not buffering, what you want to do is you want to give them the amount of anesthetic that you think is the right amount, and it's always a guess, okay? And then they're numb and they're comfortable and you're working, but you know you have a long way to go. Then you want to give them the second dose of anesthetic about 5 to 10 minutes before you expect them to break through. And that augmentation will give you the same amount of time plus a little bit. If you wait until they've broken through and then you try to get them numb again, sometimes it's very hard to get that patient numb, and it's called tachyphylaxis. So the body is sort of reacting to the fact that it's feeling pain again, and it's much harder to get that patient numb. So if you want to increase duration, let's say you're doing a long procedure on the upper arch, numerous teeth, you would get them numb and then go in with unbuffered anesthetic, at 45 minutes or 50 minutes and give them that second dose. And because you want them to work for it, you want it to, you're looking for longer duration, so make them work for it a little bit. And I think you'll have the amount of duration that you need. So if duration was a problem, that's how you fix that.
Is that sometimes the issue if, let's say you miss a block on the lower and then you give it again? And is that what you're trying to talk about? Is that?
So no, so what your problem there is, and I'm assuming you need unbuffered anesthetic, is you're putting in more and more acid. So now the patient has to work harder and harder to convert the acid to a base. You follow me? So the more volume they have, the harder it is for the body's tissues to convert that anesthetic at 3.5 up to 7.4, which is what's required for the acid form of the drug to become the base form of the drug. In other words, all it is, if this is a molecule and the acid form of the cation has a hydrogen ion on it. And when the pH goes up, the hydrogen ion falls off, and now it's lipid. So when the hydrogen ion's on the molecule, literally it's one proton. It's lipid. It's water soluble. It won't go through the lipid membrane. And then when that hydrogen ion falls off, it now becomes lipid soluble, and it will go through the nerve membrane. And that's the difference. And so I call one the inactive form of the drug and the other the active form. And the body has to convert that unless you're buffering for it. And all buffering is doing, it's only working on the hydrochloric acid. It's not working on the local anesthetic. But as a result of neutralizing the hydrochloric acid, you're taking the protons off the molecules so that they can go right to work as soon as they go into the body. And I totally got too nerdy there. I'm sorry about that.
I'm just so glad there are people like you out there. Chemistry, I started in chemistry major.
Yeah, I saw you glaze over there a little bit. I knew I was going too nerdy.
But so just to sum that up, if I miss a block on the lower, buffer the next carpule, and then that will
first cartridge. Don't
I'm buffering every first one. So if I buffer the first
one, don't use it as a backup. Use it as your primate. And then other people say, well, do I need to buffer on the upper arch? It's easy to get people to know. Well, I don't know. Do you want to hurt them up there? I don't know. I mean,
right.
It's open anyway, so use it, right?
Yes.
Because once you put this together, you take the cartridge of bicarbonate and put it in the pen, and the cartridge connector, because you always put them in together and take them out together. It's good for 20 injections. Well, the average dentist, believe it or not, only gives about 20 injections a week. And so you might as well use it all up and use it on every injection so that your patients like you for every procedure instead of just the bottom. So, but yes, if you were going to give multiple injections in the same location on a block without buffering, you're going to, if the patient is probably not going to get numb for a number of hours. You'll get them, they'll call you back an hour later and say, oh my God, I'm totally numb. You said, you know what, I'm not giving you any more. Go home. And then they call you back an hour later, hey, I'm as numb as I've ever been. Can I come in now? And the right answer is yes, come right over. Right? Because that patient's just hard to get numb. And so now, if you have buffering, you don't have to worry about that. But if you're not buffering, my recommendation is you miss the first block, do a different technique. So most of us use the inferior alveolar nerve block. And then, if that doesn't work, then, what I normally say is go higher, go east, or go west, or use the Gau Gates or the Akinosi. But because you don't want to go back to the same spot. You want to go someplace different for two reasons. One, you don't want to add too much anesthetic together because that causes the problem we were just talking about, increases the acidity. But also the longer piece of nerve that gets numb, the more likely you are to completely get a full block. Mm. So you want to stretch that out. So you never want to go back to the same spot.
Interesting.
Yeah.
So difficult patients, and then we kind of all have them, right? I find them like the anxious ones or the redheads or certain people that have like thicker structure. Is there anything that you can identify that you would be like, okay, I have a feeling like this would be a tough one?
I feel like the every time I say that redhead thing doesn't apply, it does apply, so, right. They definitely are a little bit different. I do find that buffering anesthetic works with them, but sometimes I feel like I have to give them a little more than I have to give other people. And so, that's just the way it is for those people. People with big, thick bone structures, you're going to have to make sure you anesthetize. Difficult to anesthetize upper molars quite often is because the diversion of the palatal root is so far onto the palate that it doesn't come through. And so quite often, if you miss this, instead of giving another buccal injection, give them a palatal injection, and all of a sudden they're numb. Another thing, with lower teeth, have you ever had, you're drilling on the tooth, everything's fine, and you hit like the mesial buccal and they go, ow, it's like, and it's just that one spot. Well, that's the mylohyoid nerve. And the way to anesthetize the mylohyoid nerve, I was taught, way down by the angle of the jaw on the inside, go in from the lingual. That's where the motor portion of it is. I don't want to anesthetize the motor portion of the mylohyoid nerve. I want to anesthetize the sensory portion. And where that turns out to enter is in foramina that are distal to the distal molar, whether it's a first molar, second molar, or third molar. And you need to anesthetize into the attached tissue immediately posterior to the terminal molar, and they will get numb like that. And then all of a sudden, all those problems. And it's 2 or 3 drops of anesthetic because it's fixed. So when you inject into that fixed tissue, that fixed gingiva, it's like injecting into the palate. You can only get a few drops in. So there's a little bit of pressure, a little back pressure, and then all of a sudden they're totally numb. And that's the mylohyoid. About 60% of pulps of lower teeth are innervated by the mylohyoid nerve.
Am I confusing that with a long buccal?
Yes, that's a confusion. Long buccal's different. So long buccal is the nerve that anesthetizes the facial tissue on the buccal side of the lower jaw posteriorly. Now the long buccal, that can shoot in to those foramina as well, but that long buccal is a different injection. So that one you should be high and wide of the occlusal plane, and that's the long buccal. If you just want to infiltrate, so another good thing is people like to infiltrate with articaine. I don't find that I get high pulpal success, but along with an inferior alveolar nerve block, if I'm doing anything on the buccal, I will just give a buccal infiltration with articaine as opposed to a long buccal. So buccal infiltration is I just try to go to the apex, just like on an upper tooth, except the lower tooth. And I infiltrate with half a cartridge or a cartridge of articaine, and the two together work really well. And that long buccal shot actually is pretty painful. Mm-hmm. Now, you're not going to be that painful with buffered anesthetic, but you're strictly getting soft tissue. If you get the infiltration, you're going to get soft tissue and the added benefit of possibly increasing your success with the block.
So if I can recap that, if you're doing, let's say 19, you'll do the IAN, and then you go just infiltrate at the.
It's a buccal infiltration. So I pull out the tissue, and I estimate the length of the tooth, and I try to get to about where the apex is. Okay. Depending on the height of the vestibule, you triangulate on that depth, and you deposit your anesthetic right there.
Okay. And then if they're still kind of feeling something on the buccal, then you'll do the mylohyoid.
Yeah. If there's any pulpal resistance after that, then I give them the mylohyoid.
And that would be the attached gingiva distal to the terminal molar.
Yeah.
Okay. And then PDLs. Do you do PDLs then? Is that?
Yes, I mean, so I will do a PDL periodically. PDLs are really only supposed to be done on healthy teeth, so you don't want to do them in periodontally involved teeth or endodontically involved teeth because, essentially what you're doing is giving an intraosseous injection. And so you can create some osteomyelitis if it's an infected area, whether it's periodontal infection or endodontic infection. But I don't have a high level of success giving, some people like to use the PDL exclusively. There's a couple of things, PDL has to be under pressure. So you can tear some of the PDL fibers, the connective tissue, and that hurts afterwards. Plus sometimes you elevate the tooth a little bit from putting the pressure in.
Mm-hmm.
That changes your occlusion after when you're trying to finish up your job. So for those reasons, I use a PDL as a strict backup.
Okay.
Bailout injection for me.
Sure.
Done everything else, let's try a PDL or an intraosseous injection.
How about Stabident or like something like
Stabident is great. I prefer X-tip over Stabident. They're both, so you're talking about intraosseous anesthesia. Yeah. So for those that don't know, intraosseous anesthesia, you have to take a device and trephinate the bone. So you're going to go through the attached tissue and poke a hole through the cortical plate of the mandible usually, but you can do it in the maxilla as well. And then you get into the space, the medullary bone, and then you can inject directly into that. You have to pre-anesthetize the soft tissue. You only want to go through attached tissue. If you go through unattached tissue, it winds up in the drill on your slow speed. The advantage, so Stabident is just a trephinator, and then you take your needle and stick it through. X-tip is kind of a kit. It has a cannula, and so you're drilling a cannula in, and then you take a cotton pliers and you pull out the solid portion, and it leaves the cannula. So now you can stick your needle directly into that. The problem with Stabident is you got to look for the blood spot and then find the hole and get in at the same angle, and that becomes. And some people are great. It's a great. You can use a slow speed burr and do the same thing. It's just the X-tip gives you a target, and if you're worried, you can leave it there. If you are giving intraosseous anesthesia, I would not use any epinephrine. And if you're giving a PDL injection, I would definitely use epinephrine. So it's, those are the two differences.
Okay. Yeah, I've used the X-tip or Stabident once, and it didn't really.
Yeah. Where it's good? It's good for hot teeth.
Sure. Okay. Yeah. That makes some sense then. I just didn't have success with it the one time I've used it, so maybe I should try it again. But it kind of freaks me out.
When I first got started in local anesthesia, I patented so you take the X-tip, which is not my product, and I patented some that went onto it and then went back to a pump, so you could drip anesthetic in. So you have instant anesthesia, and pretty much keep it as long as you want with little soft tissue effects, so they're not feeling like they're blocked. But it would never have stuck because most dentists like yourself, I mean, it's a surgical procedure to put the Stabident or the X-tip in, or the Stabident, either one. The other thing is you can get infection around there, right? Because you're leaving a hole through the tissue and the bone, and so you get these little infections that clear up, but it's still. What's
the one machine that does the drip that like kind of beeps at you and?
Oh, so that's the wand.
The wand, yeah.
Yeah, so it was the wand, and now they call it something different, but it's still the wand. Now they call it STA, single tooth anesthesia. So right. Okay. They were, so basically what that is that's computer controlled. So they have a chip that registers the feedback in the amount of pressure as the fluid's leaving the needle. And if you're in the PDL, there's a certain amount of pressure that's required. So it theoretically tells you, it beeps and tells you when you're in. And then it also beeps as it's dripping a different beep, I think. And so, and then the wand came out, it was just a very slow injection, but theoretically it was like a 4 or 5 minute injection, right? But, it was comfortable because if you go slow, it's comfortable. And so it's a good product, and it's just another thing, right?
We tried it for our 90-day trial or whatever, and I didn't find the 3 to 4 minute That's a long time for a
Long
dentist.
time. Everybody gets tired at the end of 3 or 4 minutes.
Yeah, I'm like, it's only been a minute and a half. Like I still have double the time here. But what would my last question be? You said use epi for a PDL injection.
Yeah. So the reason for using epinephrine in a PDL injection is there's two reasons for success in a PDL injection. One is that if there's no holes in the lamina dura, then it's a pressure injection. Well, epinephrine will also strangulate the pulp a little bit. Okay, so it's going to strangulate the blood supply to the nerve as it's ending, not the pulp, but the nerve as it's ending. And we believe that is one of the reasons for success.
Okay.
The other way you get success with a PDL injection is because there is holes in the lamina dura, and now it's just an intraosseous injection. And the way you know the difference is if they get tachycardia, then there is holes in the lamina dura. And if they don't, there wasn't any. But those are the two reasons for success. The problem with the PDL injection is it's only successful about 54% of the time, according to the studies. And I didn't do any of those studies. I'm just reporting on them. So,
yeah. I don't know. I've tried a lot of different anesthetic, obviously. So the onset for me has been by far the most profound thing to my practice in terms of patient comfort. So all props to you for this. I'm very happy with the implementation of it since June 1st. I came back.
What I like to say is I'm an overnight success. It's just been 18 years now.
There it is, right? So no, this is just, I can't speak any more highly of the product. I believe in it. I mean, we met on a channel and this is our second time talking. So it's not like I'm promoting this because you told me to. This is simply, I've done it. I've put it in practice and patients have noticed a difference, which is important too. So is there something that people can contact you or get in touch with this?
Yeah, absolutely. So what I wanted to say was, so we sell direct, and then we also sell through distribution. And the distributors that we sell through are Benco, Patterson, Burkhart, and Atlanta Dental. And so if you're a customer of one of them, get a hold of them. Most of them do, I think most of them, if not all of them, do a money back guarantee, right? So you get, when you buy a starter kit, you get the pen that you're going to use forever. And then you get 4 cartridges of bicarbonate, 4 cartridge connectors. That's our starting kit. And that's that'll get you 80 injections. 80 cartridges of local anesthetic. And if it's not for you, you get your money back. So, why wouldn't you try it? I mean, it's the one thing you have to have every day is good anesthesia. Why don't you just give it a try? We also do the same thing. If you're not a customer of one of the distributors, then we're happy to have you go direct. If it's okay, I'll share my screen for a second.
Yeah, please.
That will give our phone number and also our website. And hold on a second. There we go. So that's our website, which is on pharma.com. That's customer care, which is the phone number. And if you use this code WEB10, then for Dr. Groth, we will give a 10% discount. So awesome. You can try it at a 10% discount. If you don't like it, you can get your money back. And I can stop sharing my screen now. So I'm sure everybody's got that number. And so I can see you.
It's well worth it. I mean, just even as an associate, if you're out there listening, just get it and try it. I mean, it's something that it would be a benefit to you for the future. And I think it's something that, Becky asked about sterilization of the pen itself.
Yeah. So the pen itself is really never touches the patient. Right. And so it goes from room to room. If you want, you can put it into a slow speed sleeve, and then you're using the barrier technique. But again, it doesn't touch the patient at all. So, in my operatories, they're buffering and they put the pen away. We give the anesthetic. It goes to the next patient, and then to sterilize it, you can sterilize the green port. This is disposable. Cartridge is disposable. You don't want to put the black portion into the autoclave because that will melt. You could put this in, but all you need to do is just wipe it down with Pyrex or whatever.
Yeah, wipe it. So, and just we make sure not to have it contact the patient at all. But it's a great thing. I've really enjoyed this time. I think this has been a fun You take me back to chemistry, which I have anxiety about, but I mean, at the same point, I appreciate there's people like you out there. So it's all good. Again, I can't emphasize that enough. If anyone has any questions about this product, I'm happy to answer anything, but Mick,
And you
it's a
can,
pleasure.
you have my email. So if anybody
Sure.
has a question that you can't answer, you can put them directly in touch with me.
That sounds great.
And I'm happy
So,
to take anybody's questions at any time.
well, thank you for solving a problem that many dentists, if not every single dentist has, is the anesthetic conundrum. And I can be attest to that, is that to me, it's changed everything for my practice, my patients. So truly, thank you for coming on this hour. It's been a quick hour. I didn't think it was going to go that fast, but it definitely has gone by. And
well, you're very good at what you do. You made it very easy on me to kill an hour. So that was,
it's really truly a pleasure to have all these people come on and talk. So thank you for sharing your story.
it's my pleasure. Thank you. Thanks for doing what you do. So
stay tuned for next week. We'll be
back
back on and we'll keep rolling. So, and thank you, Kinsey, for popping on too. I know you've been at the bottom behind all this, but awesome. And then, so enjoy the rest of the evening and thank you very much. We'll see you guys later.
Take care.
Have a good one.
All right, bye-bye.